Good morning and welcome to this edition, my YouTube channel Pain Free Partha. And today's topic is about complex regional pain syndromes. So it is actually complex, but I have tried to make it as simple as possible. And I will tell you some important things in the last slides so that listen to it completely so that you can treat a simple problem which is really painful to the patients and in a simple way like. So greetings from Mahatma Gandhi Medical College, Sri Balaji Vidyapeeth, Pondicherry. So if you want to know the history, it is starting from 16th century. See here, 16th century. Ambrose Para Barber and a surgeon. See, those times you see here. Made reference to the treatment of severe persistent pain syndrome after limb phlebotomy. Mitchell was characterizing a specific type of pain resulting from gunshot wounds during Civil War, and he termed as causalgia. Algia means pain. And James even told that there is a sympathetic component and named as reflex sympathetic dystrophy. An international association of study of pain made it complex regional pain syndromes. There are a lot of names: causalgia, we have heard Sudex atrophy, reflex neuromuscular, shoulder hand syndromes, RSD, reflex sympathetic dystrophy. Whenever you want to define that, see here, abnormal response to an injury, usually extremity, prolonged intense pain, vasomotor disturbances, functional outcome is bad, trophic changes. Now, there is an injury. The body responds abnormally. So, what is the response? Intense pain, which is more prolonged, associated with some vasomotor disturbances. That is due to sympathetic component. Outcome is bad. He cannot move. Motor is problem. There are trophic changes in the skin. This is what is called complex regional pain syndromes. Now you can see there is a swelling here, pain here, and there was an injury long back, 1.5 to 2 months back. This is a classical example of a complex regional pain syndromes. International Society of Pain single term in 1994 to accommodate all the clinical symptoms. Some patients may have pain, some patients may have atrophic symptoms. So that is why they said all these things should come under complex regional pain syndromes. They say it is 5%, and a few studies say 7%. What I will put it as around 15 to 20% because there are a lot of patients who are undiagnosed in India. Continuing pain that is disproportionate in time and degree. Now we have got an injury here. Okay, this injury has happened from 2 months ago. Okay, this 2 months ago injury has to heal normally. What is known cause? We know that this trauma will heal and will not have any pain. Now he has got pain. The degree is high. The time is prolonged. That is what is called CRPS. After 2 months, he is having pain and there is more intense pain. So this is what is CRPS. Very importantly, I want to stress is pain is regional and not dermatological. Now you take, there is something injury here and the wrist is having severe pain. Injury here and the wrist and all these things are having swelling and pain here. Okay. Now if you see this side of wrist, this is C8 and that side of wrist is C5. That is very important. It is not dermatomal. It is regional. The syndrome may show variable progression over time. There are two types. Type 1, no nerve injury. Type 2, there is a nerve injury. Same things can happen, but if you have an identifiable nerve injury, then you call it as type 2. What are the three classical stages? Acute stage, which I showed now. Up to 3 months, there may be swelling, there may be sweating, joint stiffness is mild, but no effusion, no fixed contractions. If you go, there is cool, warm becomes cool and is slightly bluish, and the fixed contracture are starting to happen. Atrophic stage after 6 months loses its fold hairless and changes become permanent. So from atrophic, it is very difficult to come back to the original, and functional outcome is gone. Now you can say this is some sort of dystrophic and this is sort of atrophic. Now you can see the scar. This this scar is there. The bones have healed normally, but because of the CRPS, it has gone into type atrophic stage of CRPS. There are warm CRPS and cold CRPS. And it is not that it should stay from 1, 2, 3 and all. After an injury, 3 months, not much of pain, and after 3 months, it can go to stage 2. So it can jump. Mild, moderate, or severe may be there, and symptom may be autonomic, motor, sensory. In autonomic, there may be sweating, swelling, warm or cold. That's what I told. Warm CRPS and cold CRPS. Type 1 and type 2 are different. Nerve injury is there, type 2. Motor problem, that is what is called the functional limitation. There may be some tremors, nocturnal pain, deep pain, orthostatic pain. These are very classical. The patient, if you fall, hand falls, it will be painful. The hand is like this, there is no pain. This is very important, and it happens in the night. Deep pain. These are the very 3 classical features of CRPS. You have to think CRPS if the patient is having orthostatic pain in the night. Upper limb is more common. Even it is possible in knee, shoulder, hip, etc. It can come in both sides. You can affect both limbs. That is what I showed. The limbs like this. This was this atrophic stage, and the right limb was in dystrophic stage. Both limbs are affected in that picture. Peak years is 50 females, and there may be a preceding trauma. What is Budapest criteria? Again, very simple. Continuing pain disproportionate to the trauma or the inciting agent. And after that, they should have any of these pseudomotor symptoms or vasomotor symptoms or trophic symptoms. Any of the symptoms. Skin color may change, swelling may come, sweating may be problem, motor range may be problem. Any of the things may be happening, but continuing pain. What is the specialty of pain is about orthostatic, nocturnal, deep. At least one sign may be there. Vasomotor means temperature is a problem. Edema. Motor means decreased range of movements. It may come down from 4/5 to 3/5. Last but not the least, there should not be other diagnosis. Now we have got a patient, we think that CRPS. Now if you do a Doppler, the vessels are blocked. There is no flow. Then it means it is not CRPS. We have to think of other things. Okay, so there is no other diagnosis which explains these symptoms. There may be GI dysfunction, hypothyroidism, urological dysfunction. Very important. There may be some pain, and this CRPS can cause urological dysfunction. So the patient will go to a neurologist. The patient will go to a gastroenterologist, endocrinologist with this. To correct this CRPS, then your urological dysfunction may disappear. This is what is the most important thing which I want to tell for all people who listen to this. Now, everyone gets injured. Why should 7 and 10 or 15% develop CRPS? Now, I am telling you, this is an injury. There is a sympatho-afferent coupling. This is down is sympathetic, up is afferent. There is a sympatho-afferent coupling. So, sympathetic is problem. There is a genetic susceptibility. There is a peripheral sensitization and a central sensitization. There is some link to the adrenal glands. So in a patient who has got a sympatho-afferent coupling and a genetic susceptibility, so called, they may develop in a patient where he is emotionally arousal is there and is likely to get such pain. Again, I am telling you, vasomotor dysfunction, neuroinflammation, synaptic plasticity. That is what I told, sensitization. Systemic autoantibodies, that is some inflammation. Pathological pain processing. All these things put together, certain patients go into CRPS. I've already told you, high impact injuries, loss, interesting, immobilization of more than 8 weeks, prolonged GE, distal fractures, smokers, migraineurs. So they are prone for a patient where there is a genetic, there is a psychogenic, there is a disease. That is why 7 to 15% develop CRPS. Not all patients who develop injuries, who cause operations, develop CRPS. Increase in the activity of the sympathetic response. Pain stimulates sympathetic, we all know. But here, sympathetic stimulates pain. That is why there is a afferent sympathetic coupling stimulated in patients who are susceptible to CRPS. There are a lot of other mechanisms like abnormal synapses, disruption of autoregulation of blood flow, substance P, all these things are enlarged, sensitization, peripheral and sensory, manifestation of psychosomatic or emotional. That is what I told why some patients. Abnormal coupling in a patient who is emotionally dangerous, where there is a genetic susceptibility, there is central and peripheral sensitization occurs. So these patients go into CRPS. Inflammatory changes, alpha peripheral sensitivity. Here, what I want to tell is IL-6 is increased, antibodies are increased, peripheral sensitization, NMDA is involved. In short, it's very difficult. You cannot, this can go into that and that can go into this. Clinical examination, what you'll see? There may be swelling, edema, pulse and blood pressure you have to see. You have to see the pulse on the this thing also. You have to see thyroid, urological and GI dysfunction. Confirm orthostatic pain and look for regional lymph nodes because sometimes there may be swelling and this may be lymphatic edema and there is a lymph nodes here due to some other cause. Think of diabetic neuropathy because there may be swelling here. There is also swelling here. You should think because it can occur in all the four limbs, but it is rare. So think of other diseases. Sympathetic blockade. If you do a sympathetic blockade, now what is that is? We have to see it has done the job. It has not done extra. Sympathetic blockade should increase the temperature that it has done. If the sympathetic blockage causes anesthesia here, then it means it has tracked into the somatic brachial plexus or something like that. So it should have done the block, but it should not have done extra. Because if there is a brachial plexus block, the pain is likely to disappear. Sympathetic alone is blocked and the pain disappears. Then we are sure that we are in for a sympathetic overactivity or an afferent sympathetic coupling which has caused this CRPS. What I am this thing is, many people say that you do a stellate ganglion block, your CRPS is very good. Slightly I am against it because there is some concept called SIP, sympathetically independent pain. There, if you this stellate ganglion block is unlikely to work. If you have to do some other things. So sympathetically independent pain, SIP is different, sympathetically maintained pain. SIP is sympathetically independent pain where there is no role for, I would say, very minimal role for your stellate ganglion block. SMP is present, you can see a mixed alpha antagonist as principle is blocked. Similar results of pain relief with stellate ganglion block is happen, and simple and repetition is possible with stellate ganglion block. You can again give day after tomorrow, again give after 1 week, again give after 3 months. Stellate ganglion. Routine monitors, informed consent, propranolol you should give, and then phentolamine 1 milligram per kg. You give score, temperature. You should also see the BP and pulse rate. You can do IVRE, Bayer's block with sympatholytics, no local anesthetics. So taken by noradrenergic varicosities, depletes noradrenaline, prevents further relief, and you may think, well, where is it available? Phentolamine mesylate, price of 3 brands, 1-ethylene monosulfate, all are available in India. CBC, CRP, RFT, skin blood flow measurements, thyroid profile, muscle biopsy in selected cases, X-ray and bone scan. Here I am very particular about certain things. You have done the operation. Your plate is going to be there. It has not healed. Lot of calluses will be there. After 5 months also, this will be shown in the X-ray. And the orthopedician tells, yes, healing is going on. Healing is going on. Nothing. X-ray will be showing the same thing after 1 year also. But the patient has developed CRPS. There will be partially healed excess. The patient will go back to the orthopedician. That is the major problem. As the muscle damage here, ECMAT 1, this is normal. ECMAT 2, there is some problem here. And ECMAT 3 and ECMAT 4, there is complete muscle atrophy. It has come down, it has shrunk like that. The diagnosis of CRPS is largely clinical, one of exclusion. There may be cellulitis, there may be vascular problem, there may be severe neuropathy, there may be DVT, there may be lymph nodes problems. So Raynaud's differential diagnosis, it is one of the diagnoses of exclusion. So there are so many other things. There may be simple polyarthritis. You can have arthritis here and here swelling, or here and here and swelling. Now we know what is CRPS, what are the types of CRPS, what are the stage acute dystrophic and atrophic, what are the symptoms of CRPS, and how to diagnose it by stellate ganglion block, IVRA, etc. And we should do all the things: X-ray, bone scan, vascular, lymphedema, neuritis, diabetes, neuropathy, all these things, and rule out other diseases, because this is clinically diagnosed, and by way of diagnostic test, it is a diagnosis of exclusion. What is our headache here? You improve pain and you make him move. That is what is important. Whether we know SMP or not, blocks will work or not is another thing. That is what I told. 6 ml is enough. Stellate ganglion block, how to do, what are the indications? I will be in separate videos. Certain institutions practice local lumbar sympathetic block and put neurolytic blocks along with rigorous physiotherapy. Don't jump into blocks. See, that is a problem of chronic pain management. It is likely that we are influenced by whatever we know. I know lumbar sympathetic block, I will give. What does the patient need? That is very important. What the patient needs? Patient needs a simple tramadol tablet and physiotherapy. But I know stellate ganglion. I know lumbar sympathetic. It is not that. So don't jump into blocks. There are a lot of drugs, antidepressants, anticonvulsants, steroids, because there is a role of inflammation. NSAIDs, because there is a role of local algogens formed. Topical lignocaine. There are so many drugs. I will give a combination of nortriptyline with pregabalin, and I will try flupertin NMDA antagonist and dextromethorphans. So this is one combination which I like. Nortriptyline with flupertin. Nortriptyline is related to catecholamines, and flupertin is an NMDA antagonist. Bisphosphonates have been proposed to be a treatment for a CRPS. Yes, they are available, alendronate and all. Sympathetic blocks, yes, large RCTs are needed. They have put tourniquet time is less, then there is less CRPS. Newer insights about baclofen, intravenous immunoglobulins, subcutaneous ketamines, oral tadalafil, dimethyl sulfoxide, and mirror therapy. Mirror therapy is a separate thing. Villanur Ramachandran is one of the specialists in that. I will take in non-pharmacological methods of chronic pain relief related to biofeedback and all. Spinal cord stimulation is there. Now, what all the things we have told? We have told steroids, we have told NSAIDs. All these things will cause pain relief, and we should follow it by physiotherapy. Basically, the treatment becomes a physiotherapy. We need to do physiotherapy. It is painful, and we give good pain relief and do physiotherapy. It is the combination of pain relief and motor outcome that is needed for treatment of CRPS. Now we'll go what is the pathophysiology. There is some sensory component, there is some sympathetic component, there is some psychological component, motor component, and autonomic inflammations. Now you see sensory, we can do epidurals, we can do blocks. NSAIDs and steroids. This is physiotherapy. You can do antipsychotics and stellate ganglion block. Just think of it. That is what I am very particular about. There are so many other components. You can give antipsychotic, NSAIDs, physiotherapy along with stellate ganglion block. Put in a block, which I know well, is not the answer because the pathophysiology is multiple. This is our article on electropuncture used in the treatment of CRPS. Now we can see the CRPS. It looks like after some 7 sittings, you can see the result. That is almost all veins are seen in this patient. Complete resolution with electroacupuncture. Because I will tell you again, here another case where this is ego is stimulated because this is LI4 is an analgesic point. That is why we get stimulated. Other than that, becomes points. Yes, the points will come back again. Here, this is another case of CRPS, electroacupuncture. Now I want to see LI4, 5, 6, 8, 9, triple warmer 5, P6, H7, all these things are the points which I use. Now, this is my theory. We have already told there is a sympathetic component, there is a sensory component, there is a psychological component, there is a motor component, there is a substance P and inflammation. This is targeted by what? Decreased sympathetic drive, opioids, antidepressants, stimulation. Now, this is targeted almost all endogenous motor stimulation is there, anti-inflammation is there, muscle stimulation is there, antidepressants is there, endogenous opioid is there. All these things are done by electroacupuncture, possibly targeting all the things. You give stellate ganglion block, it may cause this. But if you give electroacupuncture, yes, it is likely to target all the pathophysiological mechanisms of acupuncture. If you do a current and do this, yes, their muscle is also stimulated. What is needed is early intervention. That is very important. You go into atrophic stage, gone. 2-3 months, just think of CRPS. Good prognosis with my approach of electroacupuncture, but I have only one publication. I have not done much of RCTs. Even in 5 sittings, it becomes better. Once reverted, it does not recur. That is the advantage. But can occur in the next stand after next injury. Now it will. Now there is a swelling pain is there. You have used electroacupuncture for 5 sittings. Patient is fine now. Again, it is not likely to go bad again. Pediatric complex regional pain syndromes are there. Now what is the adult female of 50 years? That is common. Now yes, possible. Type 1 is more common. What is type 1? No nerve injury. Foot is common. Here is the difference. Epidemiology is not established. Diagnosis by exclusion. But think of thyroid and vitamin D. Do aggressive analgesics and physiotherapy. We know the definition. Okay. What is the definition? Intense prolonged pain. Vasomotor, pseudomotor disturbances. Functional motor outcome is gone. Type 1, type 2. Type 2 is nerve injury. Stages. What are the stages? Acute, dystrophic, and atrophic. Everything is gone. Symptoms. Intense pain, Budapest criteria. And then followed by your any clinical sign, vasomotor, pseudomotor. Any clinical symptoms. One symptom is enough. Mechanisms, I have told so many mechanisms. Sympatho-afferent coupling, arousal, emotional, peripheral and central sensitization, all these things. Diagnosis by exclusion and treatment is, there are a lot of blocks we can do, but it should be only sympathetic and not sensory blocks. IVRA we can do, and then electroacupuncture makes it simple. How many carvings are there in Tanjore Big Temple? There are so many guidelines for CRPS. CRPS is many times simple, but convincing the orthopedician that this is CRPS and not related to your operation is difficult. Thank you all.